Hello and welcome to our new topic. Today we will be discussing immunosuppressants, which are a cornerstone of modern pharmacotherapy in transplantation, autoimmune diseases, and increasingly in oncology. This topic is particularly important because it integrates immunology with pharmacology and clinical decision-making. Throughout this lecture, we will focus not only on mechanisms but also on how to rationally select these drugs in clinical practice. So, let's start. In this session, we aim to understand where drugs act within the immune system, how these agents are classified, and how their mechanisms translate into clinical use. By the end of this lecture, you should be able to identify drug targets, explain mechanisms, and relate them to adverse effects and therapeutic applications. This is essential not only for exams but also for safe prescribing. Immunity is broadly divided into innate and acquired components. From a pharmacological perspective, most immunosuppressants act on the acquired arm, particularly T and B lymphocytes. Understanding this division is important because different drugs affect different components of immunity, which explains their clinical uses and risks, especially infections. The immune response depends on multiple players, such as antigen-presenting cells, T lymphocytes and B lymphocytes. However, CD4-positive T lymphocytes play a central role in orchestrating immune responses. These cells act as conductors of the immune system by releasing cytokines that activate other immune cells. Therefore, many immunosuppressive drugs are designed to interfere with T-cell activation or signaling pathways, as this provides a powerful way to dampen the entire immune response. Here we see how antigen-presenting cells activate T cells through MHC2 and T-cell receptor interaction, along with co-stimulatory signals. This is a critical step because it represents the initiation of adaptive immunity. Clinically, drugs like abatacept act here by blocking co-stimulation, thereby preventing full T-cell activation. Immunomodulators are drugs or substances, natural or synthetic, which may suppress, enhance or regulate immune responses. These include immunosuppressants, immunoglobulins, interferons, and certain biologics. Many drugs both suppress and modulate immune pathways. Let's classify immunosuppressants into cytotoxic agents, calcineurin inhibitors, steroids, and monoclonal antibodies. Each group targets a different level of the immune response, as we will see in this lecture. This classification is essential for understanding combination therapy. This is a key conceptual slide showing where drugs act along the immune activation pathway. We move from activation to proliferation, differentiation, and finally effector response. Different drugs act at different stages. Understanding this allows us to rationally combine therapies and anticipate adverse effects. It is important to note that most drugs do not block antigen recognition directly but act downstream at activation or proliferation stages. We will use rheumatoid arthritis and organ transplantation as examples to understand immunosuppressants and their clinical utility. Rheumatoid arthritis and organ transplantation both involve activation of the immune system, but the clinical objectives differ significantly. In rheumatoid arthritis, the goal is to control inflammation and prevent joint destruction, so treatment follows a stepwise approach, starting with conventional disease-modifying anti-rheumatoid drugs or DMARDs, like methotrexate, and escalating to biologics or targeted synthetic drugs if needed. In contrast, transplantation requires immediate and sustained suppression of the immune response to prevent graft rejection, so therapy begins aggressively with induction phase, using antibodies, and continues with combination maintenance therapy using drugs such as tacrolimus and mycophenolate. This difference reflects a key principle. While the same immune pathways are targeted in both conditions, the intensity and strategy of immunosuppression are determined by the clinical risk. This table compares conventional synthetic DMARDs, highlighting methotrexate as first-line therapy in rheumatoid arthritis. Each drug has a distinct mechanism and toxicity profile, which guides clinical selection. Both azathioprine and mycophenolate affect purine synthesis. While azathioprine is converted into 6-mercaptopurine that largely disrupts purine salvage pathway or interferes with DNA synthesis, the other drug mycophenolate selectively inhibits de novo purine synthesis. This is particularly important in rapidly dividing lymphocytes. Azathioprine is a prodrug converted to 6-mercaptopurine, which interferes with DNA synthesis. Its clinical use is limited by bone marrow suppression and hepatotoxicity. A key point is its interaction with allopurinol and the role of TPMT polymorphism in toxicity. Mycophenolate selectively inhibits inosine monophosphate dehydrogenase, making it more targeted toward lymphocytes. It is widely used in transplantation due to its efficacy. However, it is teratogenic and can cause bone marrow suppression. This slide shows the structure of immunoglobulins, which is important because monoclonal antibodies are designed based on this structure. The variable region determines antigen specificity, while the constant region determines effector function. This concept underlies the development of targeted biologic therapies. Here we classify monoclonal antibodies based on their origin, from murine to fully human. This is clinically relevant because immunogenicity decreases as we move toward fully human antibodies. These agents target specific molecules such as TNF-alpha or CD20, making them highly selective therapies. This slide introduces biologic DMARDs targeting specific cytokines or cells. These drugs have revolutionized the treatment of autoimmune diseases by offering targeted therapy, but they carry risks such as infections and reactivation of tuberculosis. This table compares biologics with JAK inhibitors. Biologics could be monoclonal antibodies or non-immunoglobulin fusion proteins. The immunoglobulins have a suffix, mab, in their name. The biologic DMARDs act extracellularly, while targeted synthetic DMARDs or JAK inhibitors act intracellularly. This distinction is important for understanding both the mechanism as well as the route of administration. This slide highlights a key concept. Calcineurin initiates the signal by promoting IL-2 production, while mTOR mediates the response by promoting cell proliferation. This distinction is fundamental to understanding transplant pharmacology. This diagram integrates multiple drug targets within the T-cell activation pathway. Interaction with antigen-presenting cells stimulates T-cell receptor and its associated calcineurin pathway. This results in interleukin-2 production, which in turn binds and stimulates its own receptors on other lymphocytes and triggers mTOR signaling, which determines the ultimate effector response, such as humoral or cell-mediated immunity. This diagram shows how different drugs act at different levels, from receptor interaction to intracellular signaling and proliferation. Tacrolimus and cyclosporin inhibit calcineurin by binding to different immunophilin proteins, FKBP and cyclophilin respectively, while sirolimus and everolimus would inhibit mTOR. Clinically, tacrolimus is preferred due to better efficacy, while sirolimus is used when nephrotoxicity is a concern. Tacrolimus is a macrolide calcineurin inhibitor and is one of the most important drugs in modern transplant pharmacology. It acts by binding to FKBP, and this complex inhibits calcineurin, thereby reducing interleukin-2 transcription and suppressing T-cell activation. Clinically, tacrolimus is often preferred over cyclosporin because it is more potent and is associated with lower acute rejection rates in many transplant settings. However, this greater potency comes at the cost of important adverse effects, particularly nephrotoxicity, neurotoxicity, such as tremor, and diabetogenic potential. Since tacrolimus undergoes hepatic metabolism, drug interactions are common, especially with cytochrome P450-3A4 inhibitors and inducers. In practice, the key teaching point is that tacrolimus is usually the first-line calcineurin inhibitor and forms the backbone of many maintenance immunosuppressive regimens. Cyclosporin is a lipophilic polypeptide and another classic calcineurin inhibitor. Its mechanism is similar in overall effect to tacrolimus, but it binds to cyclophilin rather than FKBP, and this complex inhibits calcineurin, leading to reduced lymphokine production and diminished T-cell activation. Cyclosporin has had enormous historical importance in transplantation, but today it is often used as an alternative when tacrolimus is not tolerated. Its toxicity profile is particularly memorable because, in addition to nephrotoxicity, it commonly causes hypertension, hyperkalemia, and cosmetic effects such as hirsutism and gingival hyperplasia. Because cyclosporin also has extensive hepatic metabolism and many drug interactions, monitoring is essential. The major clinical message is that cyclosporin remains highly effective, but compared with tacrolimus it is less preferred in many modern regimens because of lower efficacy and a less favorable adverse effect pattern. Sirolimus, also known as rapamycin, is a macrolide immunosuppressant, but unlike tacrolimus and cyclosporin, it does not inhibit calcineurin. Instead, it acts through mTOR inhibition, which means it blocks the cellular response to IL-2 rather than the production of IL-2 itself. This distinction is extremely important conceptually because calcineurin inhibitors initiate suppression by preventing T-cell activation, whereas sirolimus suppresses downstream proliferation by blocking cell cycle progression. Clinically, sirolimus is valuable when calcineurin toxicity is a concern, particularly nephrotoxicity, and it also has useful anti-proliferative and anti-tumor properties. However, it has its own characteristic toxicity profile, especially dyslipidemia, delayed wound healing, and bone marrow suppression in some settings. Another important practical issue is that sirolimus can interact with cyclosporin and may increase toxicity if not used carefully. The key takeaway is that sirolimus is best thought of as an mTOR-based alternative or adjunct, particularly useful when one wants to reduce dependence on calcineurin inhibitors. This table summarizes key differences between CNIs and mTOR inhibitors. Understanding these differences helps in selecting the right drug based on patient-specific factors. This diagram demonstrates how glucocorticoids enter cells and bind intracellular receptors, ultimately influencing gene transcription. As a result, there is reduced production of key inflammatory mediators such as prostaglandins, leukotrienes, cytokines like IL-1 and TNF-alpha, and enzymes like COX-2. This explains their broad anti-inflammatory and immunosuppressive effects. Unlike other drugs, steroids act upstream, affecting multiple pathways simultaneously. Follow the numbered steps to explore. Steroids suppress immunity by blocking cytokines, inhibiting T cells, and preventing inflammatory cell recruitment. In this diagram, we see how glucocorticoids inhibit cytokine production by interfering with transcription factors such as NF-kappa B. This explains their rapid and powerful anti-inflammatory effects, which is why they are widely used in acute settings. This algorithm presents a typical clinical decision pathway for autoimmune diseases, with methotrexate as first-line therapy and biologics reserved for resistant cases. This reflects real-world practice. Standard maintenance therapy is an interesting example of clinical utility. The gold standard for long-term protection is triple drug therapy, which combines 3 different types of medications to maximize effectiveness while minimizing side effects from any single drug. Calcineurin inhibitors or CNIs are the backbone of most regimens. Tacrolimus is the most widely used CNI. It is more potent than cyclosporin and has been shown to reduce acute rejection rates significantly. Cyclosporin is used primarily if a patient cannot tolerate tacrolimus. Antimetabolites are cell cycle inhibitors. Mycophenolate mofetil is the most common second agent used alongside a CNI. It is more effective than older drugs like azathioprine in reducing rejection rates. Azathioprine is an older drug often used for patients who are pregnant or planning to become pregnant. Corticosteroid drug prednisone or prednisolone is used for both prevention and treatment. While integral to most plans, some modern protocols attempt steroid-free regimens after the initial recovery period to avoid long-term side effects like bone loss or high blood glucose. Alternative therapeutic approach also exists. Some patients may require different medications due to specific risks or side effects. mTOR inhibitors, sirolimus and everolimus are often used if a patient experiences kidney damage from CNIs. They also have unique anti-tumor properties. Co-stimulatory blocker, belatacept is given as an intravenous infusion monthly, designed to replace daily CNI pills and avoid their toxic effects on the kidneys and heart. Induction antibodies, such as basiliximab, alemtuzumab, and anti-thymocyte globulin or thymoglobulin, are given intravenously during surgery to reset the immune system before it can attack the new organ. This table highlights drugs that are relatively safe in pregnancy, such as corticosteroids and azathioprine, and those that should be avoided, such as mycophenolate and methotrexate. This is critical for clinical decision-making. This summary slide consolidates mechanisms of action across different drugs. It reinforces the concept that drugs act at different stages of T-cell activation, from receptor interaction to DNA synthesis. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!